afternoon, ladies and gentlemen. My name is Boldizsár and I would like to present my 15 months progress report in the next 10 minutes. My vision is that the best medical knowledge needs a constant update by scientific research, and my mission is to develop and refine intensive care strategies for resuscitated patients. We set the following specific goals for the last 15 months in the translational medicine program. First, an investigation of prediction scores in out-of-hospital cardiac arrest, and second and third, a comparison of prophylactic versus clinically driven antibiotics after successful resuscitation. Shortly, I would like to summarize our first project, which is a meta-analysis, the topic that I mentioned before. It's important because the incidence of out-of-hospital cardiac arrest is high. It's between 70 to 170 per 100,000 inhabitants in Europe, and the survival rates are low, average 8%. And it is relevant in the clinical practice because we can prevent the healthcare system to apply costly and intensive resources in cases of futility. So our clinical question was which is the most accurate and reliable neurological prediction score system in the OHCA cases after successful resuscitation. We made the systematic search in the last year, and the search key you can see below. And our manuscript was sent out to internal review. Thank you for the comments for the crowdsource, and we will summarize these comments and send it to language editing in the next week. And we hope we can send it to the BMC Critical Care Journal in this year. So in the next minutes, I would like to summarize the second project, which is a meta-analysis as well. We got the results in this topic, so I will show you something new. Shortly about the background. Early onset pneumonia is a frequent infectious complication after the resuscitation, due potential aspiration, during the resuscitation airway management, and immunological impairment as well. There is few available data whether the timing of antibiotics and giving prophylactic antibiotics could reduce the risk of pneumonia or other infectious complication. And these data, between these data, there is no consensus to give or not to give antibiotics before or earlier during the post-resuscitation care. So our aim is to compare the effect of prophylactic antibiotics compared with clinically driven antibiotics. Our clinical question is the following: that prophylactic antibiotics can decrease the rate of mortality or incidence of pneumonia or any other infectious complication to clinically driven antibiotics, and our hypothesis is that the prophylactic antibiotics is superior to clinically driven antibiotics. The next slides, I would like to present our results. We could perform meta-analysis with 4 outcomes. The first one is the incidence of pneumonia. There is slightly but no significant difference between prophylactic and clinically driven antibiotics. We could divide the randomized control trials and observational trials in this analysis, and there was no significant difference in these groups as well. The second outcome is the mortality at the last recorded time point. There is no significant difference in the mortality between the prophylactic and clinically driven antibiotic groups. The third one is the survival with good neurological outcome at the last recorded time point. There is no significant difference as well in the antibiotics and the control groups. And the last one is the length of stay in the intensive care unit. We could divide the observational and randomized control trials as well, and there is no difference between the prophylactic and clinically driven antibiotics groups. There was no enough data to perform meta-analysis. So there is some mistake in the slide, because it's not the length of stay in the intensive care unit, it's the length of stay of the hospital. So there is no difference between the two groups, but there is not enough data to perform meta-analysis with this outcome, and there was not enough data to perform complete meta-analysis with the duration of medical ventilation endpoint in the intensive care unit. So to conclude, we can say that in contrast to our hypothesis, the prophylactic antibiotic was not associated with an improvement in any important clinical outcome significantly, and current data does not support the using of prophylactic antibiotics in patients following cardiac arrest. But it's important to note more randomized control trial may be needed to address this important clinical question. So you can see my progress in this topic and the status of the manuscript. We started to write the article, and we would like to finish the article in the first month of 2023, and we would like to send it to at least a D1 journal. We first tried the BMC, and then any other D1 journal. And according to our neutral results, we would like to plan our own randomized control trial in Hungary to see clearly there is a benefit or there is not benefit to giving antibiotics for the resuscitated patients. Now, in Europe, there is one ongoing trial in this topic, the PROTECT trial. Gangon and his partners will include 120 patients to this trial, which is a placebo control trial, and they will check the mortality and the functional outcomes in this trial. So we'd like to plan a trial like this one. So last but not least, you can see an overview about my topics, and thank you for your kindly attention.
This is a very relevant question, no doubt about it. Although the results are negative, but still I think it's a burning issue. And I'm wondering about the antibiotics which were used in the different studies, which were the inputs for the meta-analysis. Did they use always the same kind of antibiotics? That's one. And second, what was the duration of the application? Was it also comparable in the different studies, in the prophylactic and in the clinically initiated studies? So how did you treat this potential variability in the system?
Thank you for your question. First, for your first question about the type of antibiotics, it was not an easy job to compare these studies, because in the observational studies there was a different protocol in each published studies, but in the randomized trial there was a lot of common things, such as the antibiotics. They mainly used augmentin, amoxicillin, and clavulanic acid. Most of the studies, 1.2 grams one-time dose as prophylactic, and the definition of clinically driven antibiotics was the same. The patient has to have clinical symptoms or pneumonia on X-rays or fever and laboratory parameters to say clearly there is an infection and antibiotic is needed. So to summarize, the randomized trial followed the same protocol nearly all the time, and the same antibiotics. And of course, the clinically driven antibiotics was based on the decision of healthcare providers. So there was no same protocol for this arm, but in the prophylactic arm there was a lot of similarity.
And in your own trial that you plan to launch, what is the choice for the antibiotics, and could you subtract some practical information from all those that you have investigated yourself? So certainly I can imagine that some were more attractive for certain reasons than the others, and I'm just wondering how you plan your own protocol.
It's a good question, because we have just some discussions about the topic, but we are planning to use augmenting clavulanic acid as well, because these infections are from mainly in the upper airways, and most of the cases the pneumonia is aspiration pneumonia in our center. So the augmentin, the amoxicillin clavulanic acid is a perfect choice for these ones. So I could say our plan is to use one dose prophylactic antibiotics compared with the clinical choice. So.